All right. So I am excited for the next hour for us to be talking with Judy Montgomery. She is a long time colleague of mine. We first met when we were both working for the Seminole Tribe of Florida in Broward County, Florida. And we traveled all over the place to Big Cypress and the other tribal reservations, long time ago. And she has since relocated to North Carolina, but she is such a glutton for punishment and loves this whole Baker acting assessment thing that she actually comes down to Broward County every so many weeks and does a couple of weeks of work doing this Baker Act assessment. And so I thought she'd be an ideal person to tell us kind of from the nuts and bolts. Yes, a little bit about the law, but from the nuts and bolts of what this all looks like when someone actually is doing such an assessment. So I'm going to share my screen and get her PowerPoint up. Let's see. There we go. All right. So Judy, we are waiting with anticipation.
Okay.
Tell us what we need to know.
Well, let me start out with a little bit of, there was this wonderful woman, her name was Maxine Baker, and she was horrified at some of the services in state hospitals. And she went around the world and looked at some of these hospitals that they had. And when she came back, she was a member of the House of Representatives. She came back and authored this bill that came into effect in 1972 called the Baker Act. And, prior to that, I can remember going down to the courthouse. This was when I was growing up. And you'd have to go to the courthouse to file an ex parte to determine whether and the ex parte would, the police would come out and they would bring the person to a facility and they would get they'd get evaluated there. Well, things are, with the Baker Act, there are different ways to access services. A lot of times they use what they call mobile crisis. And mobile crisis response is, there are several teams all over Florida. I don't know, there might be 44 or more. And what happens is we'll take a phone call, and determining what's going on, we'll go out to the home and attempt to engage the individual. And the individual may or may not like the idea of talking with us, and they don't have to. And if they decide they don't want to, and we don't have enough to see whether they need to be hospitalized or not, then the family has to go to the courthouse in the old-fashioned way and file an ex parte. But what happens when evaluating someone, they sometimes can hold it together very well. And that can be very disturbing to the family who were expecting to have the person carried off into the hospital. And it oftentimes doesn't go that way. But there is when we go out to the home, we can tell if somebody's on the way to needing to be hospitalized. And there are certain things that we could tell. I went to one home and the family was keeping them from going out into the street. Now, when I talked to the person, they didn't indicate that they were suicidal. They didn't want to talk with me, but they were walking around and engaging with me anyway. But at the time, I needed to send the person based on the fact that their sensorium was altered drastically. They couldn't tell you what they had for breakfast. They couldn't tell you why they wanted to go out into the street. And the family was trying to keep them from going out into the street. And so in this kind of a situation, it's like, this is somebody that can't really tell that they need care. They're having a problem with dealing with the family around them. They don't want to be in the house. They want to be out, and something's going on with them. And in this particular case, this was a person that had gone to rehab and come out 30 days later. And after 30 days, they were showing these symptoms. And so the person was sent to the hospital under Baker Act. What I need to say about that, but sometimes when people get sent to the hospital, there can be all kinds of reasons. And some of them can be medical. Like for instance, if somebody's having hormonal problems, something can happen and screw that up. They can be using, and maybe they weren't using anymore, but something had tripped the trigger in their biology, and they became mentally ill. There was a case of one person that had been smoking bath salts, and that altered them to the point where they became psychotic. And so what we try to do is to give the family some help to get them into care if we can. If we can't, then we oftentimes can make a referral for services. But you know, even with a referral for services, COVID has changed a whole lot. And if somebody is sent to the hospital, sometimes they'll end up staying in the emergency room for an extended period of time and then discharged later. So there are a lot of things that may be falling apart right now with the pandemic. And so that makes it kind of bad for somebody having to be under Baker Act, because a lot of times there really aren't the beds. You know, we have been in Florida, it's like we're the 49th in mental health funding up until the time of the Parkland shooting. And then all of a sudden there was all this money coming in to, but they focused mostly on police. So every school has got an armed police officer who is supposed to take care of everything that's going on when something goes wrong. And so what happens with mobile crisis is we are sent out to the schools an awful lot. And there is this thing that happens sometimes when someone is not letting the parents know that the person needs to be evaluated. There's a law now, because that happened a couple times, where if one of the students is in a mental health crisis, they send out the mobile care team, and we have to make sure that the parents have been advised, or the guardian. And hopefully the parents can be brought in so that they can be part of the process. If the person needs to go to the hospital, then the parents need to also, you know, be part of that experience. But there are a lot of kids that are getting Baker Acted, and there's, you know, it's creating a lot of, you know, we always have a tendency to kind of overreact at times. You know, things go too far one way and then they go too far the other way. And I'm sure Maxine would be keeping track of this. But children, you know, when children are in school and they're bullied, they suffer worse than kids that have been mistreated by adults. And kids with ADHD are 2 times more likely to be bullied because they don't fit the norm. So there are so many things to think about with this. I'd love to hear some questions. I'll just go through what I've got written down, but I would like to hear some questions anytime you want to throw them out there.
So why don't we start with that? I'll take some notes here. Is at the end of this time, what Harriet, what's one thing you want to be sure to hear about? Oh, maybe Harriet's trying to get off mute. There she is. There she is. Good, good. So what's one thing you want to be sure we talk about tonight?
Working with children, sometimes they are know what to say to get Baker acted, because I
They
work.
sure do.
And just to address that, because they'll say because they know if they say the right thing, that's what's going to happen, and they want to. That's what they want to happen, so that's how they do it.
Yeah.
That's
So
true.
being able to sort between an actual need for the hospital and someone who is using this as a coping mechanism to to get out of their house.
But
Okay.
but they can't escalate. Though that's the worry. Okay.
Yep.
If
Yep.
it will,
So how do you sort the difference? Sure.
would actually
Go
Yeah.
ahead.
All right.
We've been playing it safe a lot of the time. And if there's a certain amount of pressure for us to send a person to the hospital and the parents are there and they can be part of the conversation, there's a little more information that can be, that can be disseminated. But we do play it safe and we do send them. And I'm sorry it's like that right now, but there's so much pressure because of, there was, after the Parkland shooting, there was a lot of people got really scared for their licenses. And so that caused us to be a little bit more conservative about taking a risk. So Harriet, I'm sorry about that, but that's one of the things when the kids say the right thing and they've got the certain look and they've got the marks and they've got teachers that are talking to us about it, we send them. And I'm sure that things will get a little bit better later, but right now everybody's running on fear. And unfortunately, people are, kids are getting Baker acted and they end up, on the unit and it's like all home week, isn't it?
Yeah. Yep.
And so they come out and then they learn new things about how to get put in the hospital. But there are times when somebody, kids need to be in the hospital. I think when kids come out as transgender, sometimes they definitely need to be in an environment that's careful, because they're still sorting it out, what they're, who they are, what they're going to do, and how they're going to survive. And a lot of them never got along with the kids around them in school because the kids around them in school noticed that they were different and didn't know why. The kids are complicated. Mm-hmm. And parents are having a hard time too, I'd like to say that all the parents that I ran into were models of parental pride, but they're not. A lot of times the parents kind of worry me.
Yeah.
So I guess we'll have to give it time.
Let me get Micah in on here. Micah, you say that your facility, are you a Baker Act receiving facility, Micah, or you or that you find yourself needing to do Baker Acts with some of the residents at your facility?
Yeah, we find ourselves needing to do Baker Acts, and Harriet is correct. Children know what to say, but to take that a step further, there are times that I've needed children Baker acted and they know what not to say, so they won't be Baker acted. And what I have learned in my short time in Florida, because we didn't have a fully licensed therapist on staff, we would have to go through the local sheriff's department. And I learned that the criteria for the sheriff to Baker Act was different than the criteria for a licensed therapist. And so I did not realize that is not the case in Georgia. So if you could shed some light on that. And then secondly, my children, Harriet and I work for the same organization, but my children attend school in the local public school system. And I've had children be Baker acted at school, and I don't know one thing about it until I go to pick them up and find out they're not there. So
Yeah.
I'm curious how children can be Baker acted without the parents' involvement.
Well, they're not supposed to be. And there's a rule, there's a law now that the parents have to be advised, or the guardian has to be advised. They were a little bit lax on that to begin with, but that's not the case anymore.
Okay.
Well, and certainly this is, this is one of the things that as marriage and family therapists, we would be acutely aware of needing to involve guardians
Mhm.
and keeping them in the loop. Because we always understand that a child is a member of a system and does not have the same level of autonomy that an adult does. So yeah, that's a really, really great point. So Judy, could you speak to the difference of how the Baker Act works as a licensed professional versus the police?
The police, actually the police, the way the law is written, the police, they say the police shall Baker Act, whereas a licensed professional may. And that's interesting because the police have, they don't have the training, but they've got the onus of having to Baker Act somebody. So naturally, I think they probably have a little different way of looking at it. But what was your question, Annalyn? I'm sorry.
So you said that the police shall. So what are the criteria that an officer, because it could happen, say like a registered intern, might have to call police to the scene, to the home or to the office if there's not a licensed person on site. Because the Baker Act team is busy or whatever. So
Right.
what will the police officers be looking at in the situation that the mobile crisis team will look at differently?
Okay, well, first of all, the police can go by the witness statement of the people around the person. They can use that information, whereas we cannot. We have to go by what we see right now. But they don't necessarily want to operate that way, but that's something that's in the law for them. So when they go and they ask somebody, do you want to kill yourself? Do you want to kill anybody else? Okay. I mean, sometimes it's a lot more detailed than that, but it ends up being very similar to that. When we talk to somebody, we can, we're going to be hearing from the family because they're there, but they also, we can't use information about what happened this morning. They can show us a video and that doesn't matter. We have to go strictly on what we're seeing at that moment in time, which can sort of hamstring us sometimes, unless we have a real clear idea that the person cannot appreciate their need for care. And without care, that they put themselves at significant risk, and that it's not clear that the people around them can keep that from happening. Mm-hmm. But we ask a lot of questions, and there are questions that we ask somebody who's psychotic that we wouldn't ask somebody who was not. But sometimes we can tell by the way their eyes go and how long it takes for them to answer a question to determine whether they need to go or not. There are so many things that we see in the moment that if we're paying attention, that we can tell. The main thing though is, like, if a person really doesn't get it that they need care and they haven't done that great a job of pulling it together while we were talking with them, then we sometimes can send them, because the symptoms can be sort of subtle, but they're there. The thing that kind of gets in the way of that is that there really aren't any beds. So we have to, I balance that out with, are they going to get some help? or is this going to make things worse? There's some research that indicates that when people come out of the hospital, they're pretty vulnerable and they need follow-up within 24 hours. And sometimes people get busy and that doesn't happen. But mobile crisis is taxed with that particular requirement that we have to get a hold of them within a day after they've been released from the hospital, just to find out how they're doing. And it's a little more difficult to get people connected with care with the pandemic, but it still happens. There are still services. It's just a little bit more dicey.
Mhm.
And if a person, once a person gets on the unit, they're supposed to, this is something that was pretty important in terms of training, that express an informed consent for treatment. I remember when I got out of school, I would just rip through that so quickly. And it wasn't until later that, that I realized that I had to make sure that the person understood what I was talking to them about. Because if there is a sense of trust between the clinician and the person, and we've spelled it out very clearly, what is a guide, what will happen if they tell us certain things. If that trust is there, they're likely to say whatever they need to say to us anyway.
So it sounds like the first job if you get called to a school, a home, a practice, the first thing you do is
explain
really,
why
really
I'm there.
join. Explain
Yeah.
why you're there, and then really, really join. Really, really gain some trust. Because if they're too guarded, it sounds like you won't get the information you need.
And they may be guarded and it may not work, but at least I have to try.
Mm-hmm.
And to be able to, to treat people with respect and find a way to join with them it's real important. And a lot of times it works.
Yeah. So you're saying that as you really join with them and they at least nominally trust you to answer your questions, then
Right.
you start looking for those signs that tell you that their processing is impaired, or that they're at a place where they really are not in touch with the people around them who are concerned about them. And tell us a little bit more about that. What are some of the things that you very specifically look for?
I look for where the person's eyes are going, because there are times when, they may stop and before answering my question, their eyes go in a funny place. And if it looks like they might be responding, I'll just say, are you hearing anything? Is anybody else talking to you? And are you hearing anything? Are you hearing voices? They might say they're not, but as the evaluation goes on and I keep seeing this, I have to ask them in another way. And it's like, and there are questions that we ask people that are psychotic that, like I said, we wouldn't ask someone else. It's like, you feel like people are following you, or people are talking about you? Do you?
Voices.
Yeah.
Are you hearing voices?
And you can ask people things like that. Or do you feel like you have special powers? Are your conversations being monitored? Are you afraid that someone is going to harm you? Elevated threat perceptions can show up in a person's, posture and how they interact with other people in their family. Sometimes they will think that people are not they're like their mother is not really their mother, but is an imposter.
Mm.
And that's a fairly dangerous symptom. I would send somebody in a heartbeat if I knew that that was the case, because that's usually that means that violence is going to ensue if it hasn't already. There is I never knew what questions to ask a psychotic person or a person who was showing psychosis until I looked at this one particular screening questionnaire. I didn't like the questions particularly, but they really started me thinking about how to talk to people that are in that position. Like, for instance, do they think that someone outside the house is going to harm them? And with drug use, sometimes those people are in a tree looking into their house.
Yeah, I can imagine there are some situations where people are sufficiently engaged with other systems, such as drug dealers or the criminal element, where some of their fears are at least a little bit based in reality. But
True.
that's where talking with the people around them that know them is really, really helpful.
And there are sometimes when, depending on the caller, when the caller is talking with us and they, based on what they're telling us, we will look into to see what kind of, if there's a felony history or any history of violence. And if that's the case, then we'll come out with the police. And, for people that are going on calls after hours, we bring the police routinely. Doesn't always help, but doesn't help with rapport all the time. But it's something that can be useful if the person, if it's after hours or the person may have a history of violence and we're not sure what's going to happen.
Mm-hmm.
It's another reason why we go out in twos, because I might not see something that my partner will see or vice versa. And the two of us can kind of look out for each other and stay within sight of each other depending on what's going on.
That's a really great point. I'm sure there are times when the particular person being evaluated will join better with one versus the other, but you won't know that till you get there and get to talking to them.
Thank you. Yeah. With delusions, sometimes when people come up with delusions, I gotta wonder if, there's a hormonal problem, because that often shows up that way. When people
Right,
get,
so there could be a medical underpinning to what you're looking at. Yeah.
and there are hundreds of medical conditions that can masquerade as mental illness, which is one of the reasons why they have a physical, evaluation when they get into the hospital.
But that's getting just a little bit ahead of the timeline. So just to kind of put this in a timeline. So I'm working in my practice. I'm talking with my client and I'm recognizing that they are really different than they usually are. And they're saying things that are very unusual. And I begin to, they start to give me this information that lets me know that they're not hanging out in the same reality maybe as I am, or as the rest of the, assuming I'm in the right reality, that the rest of the world is in. And so I call mobile crisis. Judy and your partner come out and you're asking all these questions that, frankly, I don't think I've ever asked any of those questions in a therapy session. So these are like a very different set of questions to be asking to do that level of assessment. And then let's say you make the determination that, yep, they need to go to the hospital. What's the next thing that happens?
We call one of us goes outside to make a phone call to the police, and we get the police to come out. the police have to do the transportation whenever there's a Baker Act. And sometimes it takes a while for them to come out too, if they're busy elsewhere. So that's a little tough for the clinician. And sometimes we can't prevent someone from leaving. And so what we do is we follow up at the house.
Okay.
And failing that, go ahead.
I was gonna say, so either police came with you because it was in the evening, or police get called, they finally arrive. Whenever they arrive, then typically what happens?
And the police, I'm busy filling out the paperwork, and the police are looking at the paperwork and they're looking at the individual. And they start asking a few questions of their own if they feel like they want additional information. And then they take the individual in custody and transport them to the Baker Act receiving facility, or they could go to central receiving location. There's one in Fort Lauderdale at Headway Park at 4920 North State Road 7. Police sometimes will take somebody right there at Henderson, right?
Mm-hmm. Mm-hmm. And they're taken, the person is taken in handcuffs. Is that not right?
That is correct. There are very seldom times when the police will take a chance, even with a kid, which is problematic.
And can you explain how do you explain to the client, to the person being assessed, why they're being put in handcuffs?
We let them know that they're not in any trouble, that the cuffs are for their safety during transport, and that they're going to go to the hospital, and that the police will leave afterwards.
Okay, so they go straight to ER, right? To the emergency room typically?
Yes, and sometimes if there's this is like a down, there are things that are not so great about the Baker Act, as you probably know. And one of them is at the emergency room, the police may have to stay with the person if they have no security officer. And so the police will be sitting there with the person in handcuffs.
I can see how this is not very popular with police departments to have to do this.
No, and it's not popular with the clients either.
Yeah. Yeah. Yeah.
And
I have been in the emergency room for other reasons and seen police officers sitting with the person. I don't know that I ever noticed that they had handcuffs, but yeah, I have seen that. Now, to your knowledge, I mean, obviously, someone needing to be Baker Act assessed in the hospital is not as high a priority as, say, someone having a heart attack. But do they tend to try to move those people along, or are they going to be like me and sitting for 6 hours in the lobby before they get triaged?
In a perfect world, it moves along, but they can be in the emergency room for an extended period of time before they get triaged.
Wow. Do the police go into the back of when they put them in the cubicles?
Go into the sally port. If there's room there. If not, then they have to take a person no matter what. If it's a child and there's if the nearest receiving facility is for adults only, they still have to take the child in, but they have to arrange for transfer. But anytime there's transportation and transferring, there's extended periods of time, and it's not lovely.
Wow. Okay. And so I can see how during this time of COVID pandemic, that which was an awkward system to begin with is made more so because of needing to keep people safe from infection and the overwhelming demand on emergency room services.
There's also some consequences for the family. It does level a bill for services that can run into the thousands.
Oof.
And Medicare and Medicaid will pay a lot, but they are very demanding about what they want done while the person's in treatment. And if the facility's a little bit lax in getting that information, the family is going to have a heck of a bill.
Yep.
And like I said, there's no evidence to suggest that there is a lasting, wonderful effect from being Baker acted, because people end up, when they get discharged, they're pretty vulnerable still.
So once the person is in the emergency room, they get assessed by the emergency room people. And at that point, they might even be sent home. Is it possible
That is very true. Yeah, well, if you think about it, it's a big deal. They go in a squad car to the hospital, and on the way to the hospital, they may start thinking, what the heck? What am I doing here? And, by the time they get to the hospital, they may be singing a very different song. And if the evaluator believes that the person has made that shift, they can send them home.
Okay. Do you remember the time that when we were working at AIDS Center 1, where we had a client that was Baker acted, and she was in the emergency room waiting, and she,
I remember well.
I think she asked to step out to have a smoke or something. But anyway, so she steps outside to have a smoke and decided, well, since she was this far, she just went on home, and then called us to tell us that she had just gone on home from the emergency room.
Yeah, I remember what she used to say. Give me a reason to live.
That's right. Yeah. That's right. And then there's the other time that a man took himself to the emergency room, knowing he needed to be hospitalized. And he said, I'm here and they won't hospitalize me. And I said, well, they won't take you unless you tell them that you're going to harm yourself. And he said, thank you, and hung up the phone and was there for 3 days.
That's true.
But he really knew he needed to be hospitalized. I mean, that was so even though I have not done any Baker Act paperwork myself, I certainly have these stories of things that have happened. So I know that people then could be sent home at that point, or they might be then put on the unit in the hospital. And there's some very specific law about that. Could you cover some
talking
of that?
About EMTALA? No, you're not talking about EMTALA.
No, I'm talking about there's law regarding they have to be assessed.
Oh,
a
yeah.
certain number of hours. They have to be, I think it's a 72 hours. A decision has to be made. Can you tell us a little bit about what goes on in that 72 hours?
Well, a person, once the paperwork comes in, the psychiatric nurse is looking at it and begins to formulate what's going to happen from that point. If the person is going to be continued in the hospital, then they have a medical evaluation within 72 hours, no, 24 hours, 12 hours if it's for a child. And during that time, they do labs and things to determine that it's a psychiatric problem and not a medical one. And at the time of admission, they also begin initiating the treatment plan and any treatment orders for psychiatric medications that will be needed. And if there's any problems, they call the doctor to make sure, if there needs to be like chemical restraint, they'll, give them a shot of Haldol and to get them calmed down enough to be able to cooperate with, with treatment. They always, right off the bat, try to give them to sign in voluntarily. And if they have the capacity to provide informed consent, express an informed consent, and they still meet criteria for inpatient hospitalization, they try to make that happen. And if the person is unable to give that express and informed consent, they still have a series of rights that they have that that are spelled out very clearly to them.
Mhm. Mhm.
And they have to, if the person is kept on the unit for more than, for more than a few days, they have to complete the treatment plan within 5 days. And if there is going to be more treatment necessary, then the physician needs a second doctor to agree that this needs to take place. And then if the person needs extended care at the hospital, they set up a court hearing. And during the hearing, they provide the information. And if they think that the person's going to need to be in the state hospital, they'll hold them until a bed is available, unless they clear prior to that time. And if they clear prior to that time, then they are released from care and provided with outpatient.
Okay. Okay. So, and that's that, if a person needs continued care, but they are refusing to stay in the hospital voluntarily, that usually goes before, I think it's called a grand master. Is that the right terminology? Grand master?
And then
It's kind of like
they
a
do
judge.
right. And at that point, they have to determine whether the person can be discharged or whether they need to continue the person.
Mm-hmm. Mm-hmm. Right. Right. And then of course the next step after that would be, as you said, the state hospital, if they continue to be.
Boy, is it
care.
hard to get somebody in the state hospital these days.
Really?
Yeah,
Really?
it's,
okay.
A person can be, there's one hospital I'm thinking of where I used to do the evaluations for people going for the state hospitalization. And the judge would hear it the first time, send them, and deny. The second time, if the person stays on the unit long enough to get a second one. And the doctors are kind of reluctant to do these evaluations for the state hospital because they get turned down so often. And I mean, this is my opinion, okay? We're not talking about the world. This is world according to Montgomery. And so the doctors will do the evaluations, and it can be 3 or 4 times in front of the judge before the judge agrees that the person needs to go in the state hospital. Part of that might be because there aren't that many beds. And and then sometimes the person, by the time they get to the state hospital, they're only going to be there for a couple of weeks, and then they'll be released. Of course, once they've been in the state hospital, they may be eligible for a FACT team. And a FACT team is another, it's for adults that have been in the state hospital that are vulnerable to return to the hospital, and they provide wraparound services for the individual. They do the housing, they don't take them in their cars anymore because, once again, the pandemic. But they provide the doctors and the psychiatric meds and the case management that makes it possible for someone to make it in the community.
This is great. I love this timeline. I'm going to see, go to your third slide. Let's see. Doesn't want to do it. All right, let's do it this way. Come on. Well, anyway, so let's go back to the team, and what are some other questions that that the team, that our participants have tonight?
Well, it might be that we ask them all kinds of questions about their appetite, about their sleep, about who they trust, about whether they whether they do anything that's not good for them, whether they're, hurting themselves in some way. Sometimes they will have marks that we ask about. Sometimes we ask them what their opinion is about what's going on. There are a lot of different, do you ever feel like your thoughts are controlled by someone? Do you feel like, has this occurred in a way that people would find hard to believe? Did something come down from above and inform you?
Okay.
And, we talk about a lot about threat perceptions. And, it might be that, do you feel like the people around you have got your best interests at heart? What do you have, if not, then what do you think is going on? And have you ever thought that something strange was going on?
So let me check in with the tonight's participants. Does anyone have a question? Anna, it looks like you raised your hand. Yes, go ahead. Your question.
Yeah, thank you. I guess I posted it on the comment area as far as how to handle Baker Act in private practice, which I started hearing Judy. I guess I didn't know because I have never Baker Acted anyone. I went straight into private practice, so I did not work in any agencies. So
Okay.
I guess the really basic question is, instead of calling 911, I need to call the mobile crisis
Mobile
unit?
crisis. Right. Mobile crisis. What is your area? Where is it?
I'm in Davie. I'm Davie, Cooper
Oh,
City
okay.
area.
All right, then you'd be calling Henderson Mobile Crisis.
And do you have their phone number by any chance?
Let me get it for you.
Now, I would think if you dialed 911, though, they would be able to connect you to the mobile crisis.
954-463-0911.
Could you say that again, please?
954-463-0911.
I think that's the same number that it has been for the last 30-something years.
You're right. You're right, Vinny.
Dang.
Some things never change.
You're going on, you're saying all these things, and I can remember 20 plus years ago having to go through this with my sister and having to go before the judge to try and get her Baker acted. She stood in my driveway threatening to kill me and threatening to break into my house and kill her daughter and my family. And the police did nothing. There'd be times we would take her to the hospital because the crisis unit was in overload, and the hospital would give her taxi money home because she knew exactly what to say, exactly how to behave. And we'd pull in the driveway and there she'd be. Like, what the hell, man?
One thing about an ex parte, they take a long time to process. They're good for 9 days, but all the things that that the evaluator would hear, the ex parte can be a little persuasive, and nobody can hold it together completely forever. Given a little bit of time, they begin to unravel. At least that's been my experience. What do you think, Vinny?
Yeah, no, I think you're absolutely right. But timing is everything. You
It
have
sure is.
at unravel, you have to be able to capture that. And like you said, the police are like, man, all right, nah, I don't know.
Yeah.
And I'll never forget the first time my sister downed a bunch of pills and I got the call to go to the house. And the first time after like 9 years, the policeman pulled me outside and he said, ma'am, I'm sorry, but I'm going to have to Baker Act your sister. I hugged him and cried.
Yeah.
Yeah. Yep. It's a very different experience for the family, Vinny. I really appreciate your perspective
Yeah.
on that. To
Can I-
understand that it's so different from the family's perspective. Go ahead, Judy.
But
On the
I-
telehealth, usually, I'm talking for Cerebral now. Cerebral has a good system of care, and if you tell them that you have somebody that's suicidal and needs to be sent to the hospital, they will help you.
Okay.
I don't know about other agencies. I have a friend that works for Cerebral, so that's how I know that. And they did send the person.
But like you said, Judy, the assessment and sending to the hospital is just the first step, right? Of a long
Yeah.
chain of events that at any point might break down for one reason or another. Vinny, you were about to say.
No, I have even had to make a difficult choice to call off a Baker Act and get a safety plan and get all the information if I had to do a wellness check, based on a client. She was a woman of color, and a white police officer showed up, and she had already had issues with the law. And I, together we sat there and we talked at great length about this is exactly how it would go. And had an officer of color come, I might have had a different outcome and been able to get her the help sooner.
Mhm.
But it's really difficult when you're in the moment.
Yeah.
Your adrenaline's going, you're like, holy,
Mhm. Yeah.
but it was the telehealth was the scary part for me. And I guess that I'll just have to go back to the agency and be like, okay, so how do you handle this if I get in this situation?
Good
Most
point.
clients are going to be Broward County, so I'll be close enough.
Mhm.
But only time will tell because I'm not there yet. I'm still.
Well, and I appreciate that, Vinny. That's a real call out to people to take telemental health training to address this very issue, that if you're in one part of the state and your client who legally you can see in another part of the state, what's the information you have to be able to provide enough service to get them the help they need if this should happen, if they should
Right assessment.
be
Wanna be able to-
decomping and right in front of you.
Right.
Yeah. Right.
Judy, why do you think it takes so long to get the ex parte going? Is that the backup in the courts? Part of the reason I'm asking is because this has come up yesterday and today in my own practice as an option for a person's family. They're very concerned about her, whether she's bipolar or paranoid. Even the psychiatrist has not fully determined that. He and I have been in consultation about this.
Uh-huh.
75-year-old father has called me in a panic. And this is one option. There can be medication changes. She might do a PHP, or we might have to do an ex parte, which would be very hard on the family members who have to do that, but they would do it to safeguard her. What do you think? Why does it take so long? The psychiatrist I consulted with says, you just fill out the paperwork at the clerk's office, the judge
Signs it.
that's it. But so it sounds like SNAP, but your experience doesn't bear that out.
It isn't SNAP. It takes a while to get it through. Sometimes it'll come through in 3 or 4 days, but never sooner than that.
So
Even though
3 or 4 days anyway before that kicks in.
And then, mobile crisis, we're supposed to do our crisis calls within an hour. And so an ex parte is something that we have to coordinate with the Baker Act team. And because we have to coordinate with the Baker Act team, we're on their time, not ours. And so it can take hours.
When you say, so I'm confused, there's mobile crisis and then there's the Baker Act team. What's the difference?
The Baker Act team is a BSO special package
Unit.
unit of officers that they usually only have 2 on duty at a time. And they work, you know, like 9 to 7 or something like that. And they don't work after hours. But they are specifically there for ex partes. And they'll come out, but we have to wait on them because there are sometimes that they have to do other stuff. And so unfortunately there can be a little bit of a time lag.
So if you're at someone's home doing the assessment, it's not patrol that will come, a patrol officer that will come and take them. It's this particular this particular Baker Act team that will come.
If it's a Baker Act evaluation, we use any police that are available. Supposedly, we're supposed to use BSO, but there are certain, you know, sometimes you just can't wait on a BSO officer. And if but I don't know what to say. They will work with us most of the time.
Mm-hmm. Now, I noticed that we have a couple of folks in the group tonight that are not in Broward County. And so in DeLand and Jacksonville and Madison, I guess it would be important for a clinician to find out who is supposed to come do the transport and who are you supposed to call? Is there a mobile crisis team in your area?
There probably is. There's something like 44 different mobile crisis response teams in the area.
Scattered throughout the state.
Scattered throughout. I could be wrong about the number, but there's a lot.
Okay.
And it's because of the Parkland shooting, all the things that have happened since then, they're beefing up the crisis skills or the crisis response. And so I wouldn't be surprised if they
It's interesting you say that, Judy, because this reminds me that just a couple of months ago, one of our colleagues, Judy Coel, who works with BSO, was telling us about the new crisis
CIT officers.
I know this is like it's like in the movies, you know, there's this huge room with all of these monitors and computers, and they're tapped into cameras all over the county and can watch in real time, you know, where if there's an active shooter, they have cameras they can turn on and watch where people are in real time. And so if you want to learn about what else is going on, and apparently Broward has this, but apparently there are others as well throughout the state. So go on to YouTube and look for that that workshop as well, to talk about what else is being put in place from law enforcement point of view to track and be aware of things like active shooter and this sort of thing, and which is also grew out of the Parkland the shooting. Yeah. Yeah, so there's many things that they've come out of that.
And since the Parkland shooting, there's been like 44 schools in the nation that have had shooting events where someone was killed.
Yeah. Micah, do you have any additional questions this evening?
I don't. Thankfully, we have a great relationship with the local sheriff, and they are always incredibly helpful.
That's
even
great.
when they're not able, because the kid doesn't meet their criteria, they are really only a phone call away. Now, we're out in very rural part of Florida, so it takes them a while to get here, but they are always supportive of us and of our children. So I feel like there is a mobile response team that will come, but just our sheriff has been so good that we just go through them. We did have a situation that I would appreciate your perspective on. We had a child that we were concerned about, and we had been concerned about for a couple of days. We took her to a regularly scheduled psychiatric appointment, and the psychiatrist agreed that she needed to be hospitalized. she was transported to the hospital about 2:30 in the afternoon. And that doctor was on that team. But a doctor later in the afternoon determined that she did not need to be hospitalized, and therefore she never left the waiting room of the hospital. But again, the sheriff transported her, and so we were not there. We found out the next morning that she had literally spent the night in the waiting room of this hospital because the second doctor determined that she didn't need to be hospitalized. My question to them was, when do the two doctors come together? And I
They-
never got an answer.
The two doctors come together when somebody needs extended time in the hospital. Then that's usually about it.
Yeah, and
Unless-
this is one of those situations where it would have been nice if the doctor had followed the criteria of speaking with the guardians.
Right. Yeah, we got a call from the child that said, Miss Micah, when are you coming to get me? They're not taking me here. And
Oh,
that was
wow.
the next morning. And so that didn't sit well with me, but I never got, I called and I never got an answer.
Well, Micah, I not that you're going to like what I'm about to say, but I can say that the first thing that jumps into my mind is that if that happens again, you should send a staff member to sit with that kid
That's exactly
right along with
right.
the police officer. And so that when the doctor speaks with the child, that the staff member is there to talk about what they've observed and the concerns that have been going on for several days.
That is exactly right. But typically they will call us. They typically involve us. They have to get consent from us to even assess them. So I don't know how the doctor ruled out the criteria when they never got consent to treat. I have no idea. It was
so
the
here's
debacle from the very beginning.
here's where having a good relationship with all of these service providers. So you say you have a great relationship with the county sheriff. Wonderful. That or for those of you in Broward County, having a good relationship with the local PD to where your practice is, I think is really, really important. And I think it sounds like you're going to have a relationship with the hospital administrator and whoever is the director of the psychiatric unit, so that you have a person to directly go to complain when things aren't followed by protocol.
Yes.
Doesn't mean that it'll always go the way you hoped it was, but when they don't follow the law. And so I think that's really, really important.
Do you have any guidance though in how to do that? Because it's in a larger city. It's about 90 minutes away from us. So
wow. They mean the hospital, they mean the receiving facility is 90 minutes away.
Yes.
Okay. So how did you develop such a great relationship with the county sheriff?
We are a small town. The whole population of the county is about 40,000. And so we end up at the same events and just have gotten to know each other. And
well,
we've had
it may be time to go to the hospital's gala as well.
Okay.
And just straight up develop those relationships.
I can do that.
Yeah.
Good. That's good feedback.
Yeah. Bob, before we close out tonight, I want to give Sonia, our one registered intern, a chance to ask a question. Sonia, what is your reaction to all of this stuff this evening? I'm assuming she's still here. Yep, there she is. Finding the mute button. There she is.
Sorry. A licensed clinical social worker, I'm told, can Baker Act. Yeah. In that case, would that person be required to call the police? In other words, to do the transportation to the hospital?
Only the police.
Let me clarify for you, Sonia. All licensees under 491 and 490. So that means licensed mental health, marriage and family, social work, and psychology and psychiatry. All of them can do the Baker Act paperwork. In other words, can do the clinical assessment and do the rest of the paperwork. So Judy, can you speak to the transportation question?
The police are the only agency that is capable of providing safe transport of Baker Acts. That's not very pleasant. Or they can, if the person has a medical condition or they're elderly, the police will send a medical, an
Ambulance?
EMS, yeah, an ambulance. But
Okay.
the police have to follow along behind them
Mhm.
because it has to be safe.
Yeah, Sonia,
Oh.
you want to think about someone who might be very agitated about being taken to the hospital. They could attack the driver. They could jump out of the
Right.
car. It's just not a safe situation. This is
Right.
why we don't encourage parents to transport the children to the hospital for the same reason.
Okay.
Yeah. But so thank you for that question, Sonia. Thank you.
Actually, we oftentimes will ask the parents if they can transport the child to the hospital if they're voluntary.
Right. If it's not at a certain acuity, I'm assuming.
Right.
Okay.
Right. So it depends on how agitated the person being assessed is. Okay. All right. Well, we have a little case study here. I've had it up long enough that you guys could have read it by now. Any questions about this little case study that Judy's taken the time to put together for us? Anyone have any questions about that?
Not yet.
I think the thing about this is, you think about when you make lasagna, there are layers and layers and layers of stuff that go into the dish. And, for most of the time when people are beginning to lose composure and begin to feel overwhelmed, it's because of layers and layers of things that are going on a lot of times. So there's a question that we often ask is like, what has happened? What has happened to you? And when, that may, that's when the stories come out. And, here's a person that there are so many things that are going on. There's the storm, the hurricane, power outage, financial difficulties, and the fact that the insurance isn't going to pay for the house damage. And so, that's kind of it. She started out with depression, and now she's got all these things that are going on top of that. And so her coping has failed.
Mhm.
If our hurricane insurance won't cover the repairs, maybe my life insurance will. Well, it won't. It won't. I think there's a suicide clause that knocks that out of the water. But
yeah. And in this case, I'm immediately noticing about the client Corinne's husband is there. And so he becomes a resource to find out how are things changing. And I'm sure it's Eric is the husband is the one that made the call that brings us in to do the assessment. Yeah. So but I love how this is this wonderful layered, that no one thing tips people off the balance. That usually it's, as you said, layers and layers of things that have happened, and that, but by the grace of God, any one of us could be pushed to that limit if there's enough layers and lack of support. So yeah. Appreciate that. All right, you have one last one here. Some of the resources that you have for us. The Columbia Suicide Rating Scale. Again, if you go on YouTube to the Florida Interest Network YouTube channel, we have an entire hour workshop on just the Columbia Suicide rating scale. So and we all cheerfully downloaded it to our cell phones when we did that workshop. So please do look at that one as well as a support to this evening's presentation. I would have advertised it as connected to those if I just had been thinking about that. But so Judy, I appreciate so much your being here this evening and talking with us And I can't thank you enough for taking the time this evening. And for everyone that attended this evening, thank you for coming. And I hope to see you at our next workshop, which I'll tell you about as soon as I stop the recording.